million members. Okay. Got it. Okay. With nearly 38 million members and offices in every state, plus Washington, D.C., Puerto Rico, and the Virgin Islands, AARP works to strengthen communities and advocate for what matters most with a focus on health, security, financial resilience, and social connection. Today's program touches on health and wellness, which is part of our age-friendly social change agenda. So, who's in the audience today? Put it in the chat. Put your first name, what city you're Zooming from. Let us know. So, Sophie, who do you see in the chat?
Oh my gosh, we have folks from all over California, but we're delighted to have folks from as far away as Missouri, Seattle, Portland, Utah, Wisconsin, Montana. Oh my goodness, so wonderful to have you joining us. I see now North Carolina and Florida. Welcome, welcome all of you to Tea and Coffee Tuesday.
Oh, that's wonderful. So glad to see so many of you from around the state and around the country. So we also have a trivia question. So let's please take a moment to answer our trivia question and put your answer in the chat. What type of tea is gunpowder tea? Is it white tea, green tea, black tea, or oolong tea? Sophie, what do you see in the chat?
Ooh, I see 3 people saying oolong, 4 people saying oolong. No idea. Black tea. What is the correct answer?
The answer is green and oolong. Gunpowder tea is a form of tea in which each leaf has been rolled into a small round pellet. Its English name comes from its resemblance to grains of gunpowder. This rolling method of shaping tea is most often applied either to dried green tea or oolong tea. Gunpowder tea leaves are withered, steamed, rolled, and then dried. Rolling renders the leaves less susceptible to physical damage and breakage and allows them to retain more of their flavor and aroma. In addition, it allows certain types of oolong teas to be aged for decades if they are cared for by being occasionally roasted. I know Joyce loves oolong tea every Tea and Coffee Tuesday. Do you have a favorite tea, Sophie?
Oh my goodness, it's between green tea and probably Earl Grey. Love it, love it.
I love green tea myself. So thank you everyone for participating in today's trivia. Well, we are delighted to have all of you join us today and hope you have your coffee, tea, or other beverage with you. And we are really excited to talk with our guest speaker, Dr. Marcia Roggio, who will discuss hearing as we age. To get us warmed up today, we have 2 poll questions we'd like to ask you first. So if you could quickly submit your answers. Do you think you could be experiencing hearing issues? Yes, no, or you're unsure? Oh, wow. Almost overwhelming. Everybody says yes. There are a few no's and a few unsure. 74% of us feel that we are experiencing hearing issues. So today's session will really be good and informative for us. One more poll question. Have you ever had a hearing test? Yes or no? Oh, 77% have said yes. They have had a hearing test. So again, today's session will really be applicable and give us a lot of information. Thank you very much for participating in the polls. Thank you for participating in the polls. It's my pleasure to introduce our guest speaker, Dr. Marcia Roggio. So we're going to make sure that we're on mute before Dr. Roggio begins her session.
But anyway, I'm here and not here. I just gotta do the banquet stuff. Yeah, we gotta go downtown.
Dr. Marcia Roggio is professor of audiology in the Department of Speech, Language, and Hearing Sciences at San Francisco State University. She earned her PhD in auditory neuroscience from the University of California, San Francisco, and her MS degree in audiology from the SFSU Communicative Disorders Program. Dr. Roggio is the chair of the California Speech, Language, Pathology, and Audiology and Hearing Aid Dispensers Board. She currently serves on the board of directors for the American Academy of Audiology as a member at large. She is past president and previous legislative liaison of the California Academy of Audiology. Dr. Roggio currently serves on the California Department of Health Services Audiology Technical Advisory Task Force. She also has a private audiology and hearing aid dispensing practice and has published numerous research articles and has given many presentations at state, national, and international conferences. But let's go over a few fun facts about Dr. Roggio. Dr. Roggio was once a bartender in Madrid. She has a Siamese cat named Gracie, and she started her audiology career working with Cochlear Implants when they were first experimental. And one fun fact about hearing, the middle ear is the size of an M&M. Welcome, Dr. Roggio. We're really looking forward to what you have to tell us today.
Thank you, Jacqueline. Thank you to California AARP for inviting me to speak today about hearing as we age. So I'm going to share my screen and hopefully everyone can see the screen.
Yes.
Okay. As previously advertised, we're going to talk about hearing as we age. And let's define what hearing loss is. The World Health Organization and a slew of others have defined hearing loss as follows. A person is said to have a hearing loss if they are not able to hear as well as someone with normal hearing, meaning hearing thresholds of 20 dB or better in both ears. Well, let's look at what that means. This is an audiogram, and I saw from the poll that many of you have already had a hearing test, so you perhaps know what an audiogram is. This is the document we use to plot hearing thresholds. That is the softest levels that you can hear at these particular frequencies that you can see along the top here. You might ask, well, why do you choose those frequencies? It's because these in the middle here between 500 and 4,000 hertz are the most common frequencies used in English and probably most other languages as well. Over here on our vertical axis, we see the decibel level or loudness. So up here, we're looking at very soft sounds, down here at 120 very loud sounds. So thresholds are plotted on this audiogram, and we can tell, depending on where they are plotted, whether someone has normal hearing, that is thresholds that fall 20 dB or better, as it said in our definition, or if the thresholds fall in this range of 35 to 40, we would consider it a mild hearing loss. If the thresholds fall in the yellow area here between 40 and 55, it's considered moderate. If the thresholds fall between 55 and 70, it's a moderately severe. 70 to 90 is severe. And any hearing thresholds that fall from 90 and higher is considered a profound hearing loss. So if you've had a hearing test, you can look at a graph like this and determine what degree of hearing loss, but it doesn't tell the whole story. Let's look at these levels of hearing loss in terms of how well you can understand speech. If your thresholds fall between 0 and 24 dB, that's considered pretty normal hearing, and you wouldn't have any particular difficulty hearing someone talk to you at a conversational distance. If your thresholds fall between 25 and 39 dB, that's considered a mild loss, and you might have difficulty with faint speech. Faint speech meaning someone who talks softly, some of the elements of speech that are unvoiced, like S's and T's and F's. If your thresholds fall between 40 and 69, we consider that a moderate loss, and then you'll have difficulty even across the table from someone. You're going to miss a fair amount of what they say. Between 70 and 89, that's a severe loss, and then people are going to have to speak very loudly to you in order for you to hear them. For thresholds at 90 and above, as we mentioned before, that's a profound hearing loss, and you really can't use your hearing very successfully to understand speech. You're going to have to use lip reading, as many of these other categories do as well. But when it's a profound loss, vision is the primary mode of understanding. So what are the effects of hearing loss on the comprehension of speech? And I put in these comments that I hear as an audiologist all the time. And the number one thing I hear is, I hear, but I don't understand. And we'll talk a bit in a minute about why that is the case. Others say, well, I can hear, but it sounds muffled. And very commonly, people will say, well, if it's one-on-one, I can understand pretty well, but put me in a group and I'm just sunk. I can't understand anyone. I can't understand if there's a lot of noise in the environment. I can't tell where sound is coming from. So that's called localization. I cannot tell, and that's disconcerting to people when they can't tell where it comes from. And sometimes people say, well, I just give up and pretend to understand. I nod my head and I don't get it. And hopefully I'm not wrong. Let's see. So let's look at the types of hearing loss. Let me make sure I'm in the right place. Yeah. So these are the most common types of hearing loss. The top one is called conductive. And usually that occurs in children because it can be caused by middle ear infections. Not that adults don't have those too, but commonly we see that in children. But we do see impacted earwax with adults, and we have a conductive loss. That means the inner ear, which is kind of where sound is decoded, is working okay. It's just that sound can't be conducted into it to be interpreted. The most common hearing loss we're going to talk about today is sensory neural. And that means that the inner ear is damaged, the cochlea, where the hair cells are sitting that decode sound, that those are damaged. And that can occur from a number of different factors, from aging, excessive noise exposure, ototoxic drugs, meaning words like drugs like cisplatin that's used to treat certain cancers, aminoglycoside antibiotics that are also used as life-saving antibiotics. They cause hearing loss. Genetics and a number of other diseases. The third type of hearing loss is called mixed, and that's when an individual has two causes for their hearing loss, a conductive cause and a sensory neural cause. For example, such as somebody who has a hearing loss due to aging, but they also have an ear infection. So they can have two problems. How common is hearing loss in the United States? Well, according to the National Institute on Deafness and Other Communication Disorders, approximately 36 million Americans have some degree of hearing loss. And as you can see by the next set of data, there's a significant relationship between hearing loss and age. Approximately 18% of individuals who are 45 to 64 will have hearing loss. 30% of adults between 65 and 74 will have a loss. 47%, or nearly half, of people who are over 75 years will have a hearing loss. And at 80% of those over 85 have a hearing loss, at least in our country. And I don't think it's very different anywhere else. So you can see as you age, the incidence of hearing loss becomes more acute. And it's typically that more men have hearing loss than women, and they usually have it in a greater degree. There's lots of theories as to why that is the case, but often men are just exposed to more noise occupationally and recreationally that leads to hearing loss for them more readily. Hearing loss generally, for most of us, develops gradually, slowly. So the brain kind of adapts to it, and you don't actually realize that you have a hearing loss until it gets to an acute level. So what are major causes? Well, we're going to focus on one major cause of hearing loss as we age, and that's called presbycusis. Presbycusis is a Greek, comes from Greek word presby, which means elderly or aged, and acousis, the ability to perceive sound. So you can see it makes perfect sense that that's what hearing loss and aging would be called, presbycusis. And it comes from changes in the inner ear that occur with aging. Because our ears are typically the same age, it affects both ears equally, and it has a gradual onset and a gradual development. This is just a graph that shows, if we look at the number of people with hearing loss over the years, we can see our bar graph grows exponentially from age 20 to age 80 in terms of the presence of hearing loss. And then it's not that there's less hearing loss after age 80, it's just that there are less people. So let's look at what presbycusis looks like. If we look on the left side, we'll see an electron micrograph of the cochlea, or the inner ear. And we can see that the hair cells, which are a very important part of coding sound, are missing, as we can see here. We see them still here, but it's missing right here. We also see that there's no nerve fibers. So once hair cells are missing, the nerve fibers that connect to them and that take sound to the brainstem and to the brain are also missing. So we've lost part of our anatomy here. What that looks like in terms of an audiogram, if we look on the right, we see the red circles are right ear thresholds, the black X's are left ear thresholds. And looking at our audiogram descriptions before, we're looking at a mild to moderately severe hearing loss in the high frequencies that comes from presbycusis. You notice this is a kind of a gently sloping loss that gets worse in the high frequencies. And that's very common in terms of what a presbycusic hearing loss looks like. What that means is you can hear vowel sounds pretty well. You can hear voice consonants like ba, da, ga, but sounds like st, sh, S, T, F, P. Those are very hard to hear, especially in the, with a loss in the high frequencies. So this is a collection of pictures here. Let me take you through them here. Over here on the left, we're looking at the changes in the central nervous system with aging. And we're going to see changes in neuron size and number decrease that happens with age. So if we look over here on the left, we'll see A. This is the auditory system. You can see it's pretty complicated. Here's our ear, out here our cochlea. We see the pathway winding its way through the brainstem and up to the auditory brain. And anything can go wrong anywhere along there, but mostly with presbycusis, we're looking at a problem here. B shows us inner hair cell loss. So hair cells are, without going deeply into an anatomy lesson here, they're essential parts of our hearing. That's what codes sound in the inner ear. And we can see as this is a mouse study, but as the mouse gets older, we see fewer and fewer hair cells and nerve fibers. Also, if we look here at C, we can see thresholds are going up. Okay, as we get older, our hearing gets worse, our thresholds get higher. And D is gray matter actually in the brain, the volume of gray matter, and that's where the cells are. It gets less. So we're actually losing brain matter as we get older. And that takes us to this middle picture here. We're seeing males in blue, females in red, and this is brain weight over time. And we can see that the brain gets less and less heavy. Why? Because we're losing gray matter. If we look at these nerve fibers down here in the dendrites, we see nice, healthy ribbon here with lots of dendritic aspects to it. If we look down at the age, we start seeing them go away. They're just far less of them. Same thing over here. If we look at a young person, we see lots of dendrites and lots of connections, but as we age, it gets less so. So let's look at some physiology, or pathophysiology is another way to say it, in terms of what's happening in the central nervous system as we get older. Well, we believe that gene expression that used to be responsible for operating the mechanics of the inner ear, there are some changes that occur. We start having less neurotransmitters, so cells don't talk to each other the way they once did. That also slows down the information getting from one place to another. You saw that elaborate pathway from the ear to the brain. Everything slows down in that process. We also see changes in myelinization. You might remember from biology way back when that myelin coats the outside of nerve fibers, and it helps conduct information. But if we start losing that, it's going to slow down our ability to conduct information. And that's going to create what's called latency problems. Things are going to slow down. And we'll look in a minute at why that's a problem. Also, we look at plasticity changes. The ear is organized very systematically, high frequencies at one end of the cochlea, low frequencies at the other, and they feed information to the brainstem and the brain exactly in that tonotopic organization. But if you're missing half of your hair cells, you're missing some of the anatomy and the information that goes up to the brain, and the brain's going to reorganize when that happens, but not sufficiently to restore hearing. So let's look at the normally required speed of processing of sound. We've just been looking at the changes that can happen in slowing down when we don't have gene expression, myelination, all those kinds of things, helping us get information from out in the periphery to the brain. So normally, in order to process sound adequately, you have to listen at a rate of about 2 to 3 words per second. You have to discriminate word boundaries. So for example, in the phrase, he saw the car go versus he saw the car go. If you can't tell the difference in those word boundaries, it all runs together and you misunderstand what people are saying. You have to identify individual words. You have to put those together with the meanings that you have for them. You have to determine the semantic and syntactic structure to make sure what you're hearing is correct. So you have to remember what you hear long enough to say, well, that didn't make sense. Let me rethink that and come up with a better idea of what somebody just said to me. When someone is speaking very rapidly, we are not able to process that very well as we age, and put us in a noisy environment, and then we're really sunk. So everything slows down in terms of our ability to process speech. Even if you had absolutely normal hearing, as your brain ages, you're just not able to process fast speech the way you once did. So if many of you have teenage grandchildren and they're talking to each other and you're kind of lost, even if you had normal hearing, you couldn't follow them very well because they're talking so darn fast. We need to be able to fill in what we miss, and that's just harder and harder to do the faster it goes and the more words you miss. So what happens with cognition as we age? Because that's going to play a pretty important role here. Well, as we just got through saying, the speed of processing declines or slows down. We also have more difficulty with working memory. We need more resources operating at the same time to accomplish the same task we used to be able to do with our eyes closed. And there's attentional changes. We're not able to ignore distractive things, or inhibition. It doesn't work quite as well. Other things that are adding to the piling on here are visual impairments with age. If we have to rely on looking at someone's face, lip reading a little bit, things like that because of our hearing loss, now we have to contend with visual problems such as cataracts. which, as you know, is a progressive retinal disorder. It's a clouding of the lens, but cataract surgery is pretty successful these days at lens replacement and restoring vision amazingly well. Glaucoma, though, impacts peripheral visual fields. Diabetic retinopathy, as some of you may know, certainly can lead to blindness. And macular degeneration, of course, about 20% of people between 75 and 85 have that. And that's the macula it's like the cochlea, it's like the hair cells of the cochlea are being destroyed. In addition to vision, we often have an arthritic hand. You know, that's as you, I'm sure, know very well, inflammation of joints. There's a pain, there's reduction in mobility. It's trying to use our hands. It just makes it really difficult. We also lose sensitivity in our fingertips. So if we're trying to deal with a little hearing aid, trying to turn it on and off, open the battery door, put in a little battery, those are all very challenging, let alone trying to clean out little holes that are in the hearing aids and operate the controls. All of those are really difficult if you have vision and an aging hand with arthritis as well. Very complex. So why does hearing loss matter? Well, this is the biggest reason. We all like to communicate. In fact, you're all here because you like to communicate and like to learn things. It's just in our nature. We like to gossip, we like to debate, we like to tell secrets, we like to do a lot of things. Let's look at some of the things we most commonly use communication for. We're expressing our thoughts and ideas, and we do so in a very fluid exchange. Usually it's back and forth, no problem. We can express our ideas fluidly, if you will. We like to describe our experiences, tell somebody about our vacation, what we did yesterday, our doctor's appointment, whatever it was. We explain. We do a lot of explaining how something works or why we did something we decided to do, but we use a lot of explanations. Definitely, we want to express our points of view. We all have an opinion on everything, right? We want to influence others. Sometimes we want to talk somebody into something, or they're going to talk you into something, or try to do that. Certainly, we use the communication to express displeasure. If we're unhappy with something, we certainly want the important parties to know about that. But we also use it for humor. We like to make people laugh. We like to laugh ourselves. And we like this exchange. Humans are natural communicators, and we use it to develop strong relationships with people. We use it to develop trust among our friends and family and colleagues. It helps us with decisions. It facilitates information sharing, which is really important, and more. So we really like to talk to each other. Well, what happens when you have a hearing loss on communication? That easy flow of things that we like to do. We begin to have what's called conversational disfluency. We have to ask people to repeat things, and sometimes more than once. And after you've asked 2 or 3 times, I don't know if anybody of you have ever experienced it, but people will often say, well, never mind, which of course is highly insulting, and it makes you feel left out. You also misunderstand key words. And when you misunderstand key words, because some of those sequencing problems, you lose important information. And then you don't know what the topic is, and it's very difficult to follow the rest of what somebody's saying. You require the TV volume to be louder than others. I can't tell you how many families come in to see me because it's not the person with the hearing problem, obviously. It's their family saying, enough already with the TV, I can hear it from the street. Difficulty hearing on the phone is a common complaint. Absolutely common is difficulty hearing in noisy environments. In a group, in a restaurant, in a family gathering, sometimes people feel just lost with a hearing loss. It also, practically speaking, means that your safety can be compromised. If you can't hear the tea kettle whistling, someone breaking into your window, or traffic issues, things like that, your safety is compromised. And nothing more exasperating than missing the punchline. Everybody's laughing and you don't know why, because you missed the punchline. So what are some of the social and emotional consequences of hearing loss? Well, what we find is that with hearing loss untreated, typically people will socially withdraw. They'll become more and more isolated. They'll decide, I don't want to go to that wedding. I don't want to go to that Thanksgiving dinner. I don't want to go out with my friends because I struggle. That leads, unfortunately, to depression or sadness, because as we mentioned, we like to talk to each other. We're very social generally. And if we can't do that, we become depressed. Some people feel shame that they have a disability. They feel guilt or frustration. Some cultures are more heavily loaded with that kind of consequence. Some people feel embarrassed, and that makes for low self-esteem. And it's also difficult to interact with your family, and that can cause tensions. So hearing health equals mental health. Okay, let's look at that again. Hearing health equals mental health. So if your mental health is good, your hearing health will be better. So Dr. Frank Lin is a professor of otolaryngology and epidemiology at Johns Hopkins. And he and many others discovered in the last, I would say, 5 years or so, perhaps longer, that hearing loss is independently associated with accelerated cognitive decline. Let's read that again. Hearing loss is independently associated with accelerated cognitive decline, dementia, and poor physical functioning, as well as psychological decline. So he's seeing that people with untreated hearing loss have faster cognitive decline than people with hearing loss whose hearing loss has been treated. So let's look at some of the factors that are playing in dementia. Decrease in cognitive functioning, meaning all the higher level functions that we do, such thinking, calculating, decision-making, language. Those are all in decline. There's a damage of brain cells, we know, which leads to loss of memory, a general disorientation, certainly difficulties with problem-solving skills, and decrease in processing visual images. It sounds odd, but that certainly occurs, so that you no longer recognize people, for example. And certainly loss of language skills. So your retrieval of words that you want to say, putting a sentence together, communication definitely breaks down. So this is risk of dementia with untreated hearing loss. So if we look at our degrees of hearing loss from no hearing loss to mild, moderate, severe, as we looked at before, versus the hazard ratio, hazard meaning the increased likelihood of developing dementia, we see that the greater the hearing loss untreated, the more likely you are to have dementia. That's what this is showing you. The greater the hearing loss, the more likely you are to have dementia. So, but let's sorry, my mouse makes me jump around here. Let's look at risk of dementia a little more closely. Does that graph that we just looked at mean that everyone with untreated hearing loss will develop dementia? Absolutely not. Does it mean that everyone who wears a hearing aid will not develop dementia? Absolutely not. So we don't want to scare people into thinking, gosh, if I don't wear a hearing aid, I'm definitely getting dementia. That's not the point we're trying to make. The point we're trying to make is we're looking at the risk factors. So it appears that there's a greater chance of mental decline as hearing loss it gets greater, and it will slowly get greater. So Dr. Lin and his colleagues also looked at the speed of decline, and he found that older adults who have untreated hearing loss had mental decline 30 to 40% faster. So adults with untreated hearing loss had faster mental decline. He found also that they had the same mental decline of 7.7 years on average as someone with normal hearing showed in 10.9 years. So that's a much earlier onset of decline. Now, I know this is a very wordy slide, so let me go over each of these issues. So this is the link between hearing loss and cognitive decline. He's speculating that there's three things that could be involved in this. And one is that hearing loss makes us feel isolated. We find it hard to join in conversations in social situations. We don't go to the wedding, we don't go to the dinner, we don't go to the family gathering. So that makes us feel lonely or isolated, which we feel is linked to dementia and the speed with which it sets in. The theory is that isolation leads to an increase in cortisol. Cortisol is a stress hormone, and it causes inflammation. And in people with untreated hearing loss, we see large amounts of cortisol in the brain, causing inflammation and thus deterioration of brain tissue. The brain also appears to have to work harder to process sound if an individual doesn't hear very well. The theory is that we have kind of a fixed amount of mental resources that we use for all those things I mentioned: decision-making, calculations, language, and so on. If we have to use all of our brain resources to hear, like effortful listening, we're going to deplete our cognitive resources. We're going to have cognitive overload. Another thought of why we're having cognitive decline. Also, as a matter of practicality, if the anatomy of the cochlea and the eighth nerve, which takes the information up to the brain, has been damaged due to all those factors we talked about before: aging, genetics, diabetes, noise exposure, certain drugs, there's simply less information getting up to the brain, and the brain doesn't function well when it doesn't get normal input. So Dr. Lin's feeling is that hearing loss and cognitive decline are possibly related to all three of these things: feeling isolated with a lot of cortisol creation in the brain, cognitive overload, where we're having to use so much of our cognitive ability to understand someone, and therefore depleting our resources, and simply not having the anatomy taking the information up to the brain because of our hearing loss. So here's a couple of other pieces of information that have to do with brain changes with hearing loss. Dr. Arthur Wingfield, who's a professor of neuroscience at Brandeis University, he looked at brain imaging studies that showed that adults with hearing loss have less gray matter in the part of the brain that receives and processes sound from the periphery. That's less gray matter in the area of the brain that receives and processes sound. Kind of a scary notion. And then that begs the question then, does wearing hearing aids prevent dementia? Well, I wanted to tell you about a couple of studies that I was able to find. Two studies, one French and one British, found that elderly people with hearing loss who use hearing aids eliminated the risk of dementia. That is, people who wear hearing aids had the same incidence of dementia as people who do not have a hearing loss. So wearing hearing aids, treating your hearing loss seems to have a strong consequence for maintaining your ability to think and calculate and use your language. Another French study showed that patients with cochlear implants showed marked cognitive improvement 1 year after implantation. So you can regain some cognitive ability if you can hear well. Lastly, a study at Columbia University of 100 seniors between 80 and 99 demonstrated higher cognitive ability among those with hearing loss who wore hearing aids versus those who had hearing loss and did not wear them. So I hope we're making the point here that wearing hearing aids can slow, reduce, and even reverse the effects of cognitive decline, at least for some people. So what can we do about these aging realities? Well, times are changing. Seniors are much more commonly using cell phones, computers. They're the fastest growing population to use the internet. So more power to us, huh? Because we are we're getting in the swing of things, we're staying in it. And I have to applaud everybody who's here at this talk because you're engaged, you're here, you're trying to learn, you're trying to stay involved. So who do you see for hearing testing, or what kind of hearing health professionals are out there? There are audiologists. Audiologists have to have a doctoral degree to be licensed in California. So that means they have a lot of training. Most doctoral training programs are 4 years of training with a lot of hands-on work. They study not only hearing, but hearing science and hearing loss. They're trained to diagnose and treat hearing loss with hearing aids and cochlear implants. They also work in many settings, from hospitals to private practice to clinics to industry, just a whole slew of for manufacturers and so on. And they treat everyone from infants to the elderly. Hearing aid dispensers are another group of individuals who typically have a high school diploma, and they have to pass a written and practical state examination to dispense hearing aids. So they can do hearing testing, but only for the purposes of fitting a hearing aid. They can't do diagnostic hearing tests the way an audiologist can do. And then otolaryngologist is a fancy word for ear, nose, and throat doctor. Typically, their physicians are there to treat symptoms of pain, drainage, bleeding, things like that. But in reality, 85% of people with hearing loss cannot be helped by a physician. So if you have presbycusis, for example, there's really very little a doctor can do for you. But if you have a mixed loss or a conductive loss, certainly they can. So let's look at some other things we can do about our hearing loss. This is just a slide I put in. We could have a whole nother talk about hearing aids. But if we look at our picture here, we can see that there's a big variety of styles and sizes of hearing aids. There are what are called custom hearing aids. Custom means that a mold is taken of your ear, that mold is sent to a factory, and the hearing aid is made to fit you exactly, something like a dental mold that you've probably had before. And you can get those from a large hearing aid that fits in the entire bowl of your ear. You can get a somewhat smaller one called an in the canal, which is a little bit smaller. That's the one we see down here. A completely in the canal, a CIC, which is a really tiny little thing like here, and an IIC, which is the tiniest one, goes deep in your ear. So nobody's going to see it if cosmetics is a concern. Behind the ear hearing aids are kind of going away. This one here with the ear hook and the ear mold, we don't see those much anymore unless somebody has a very profound hearing loss. And then there's hearing loss called RIC. RIC means receiver in canal. And that's what this is. It's a small behind the ear hearing aid with a receiver coming down right here at the end and a little disposable dome on the end that goes deep into your ear canal. Very comfortable. Today's hearing aids can pair to a cell phone, so you can stream phone calls directly into your hearing aids. You can listen to podcasts and music through your hearing aids. But best of all is hearing phone calls, and it streams to both ears at the same time, which is really helpful if you're trying to listen to somebody on the phone and you're in the mall or you're at some noisy place. RIC hearing aids can they're really developing rapidly in terms of all they can do. They can connect to an iPad, for example. So there's a lot of Bluetooth connectivity now that we didn't have even 5 years ago. So when I started fitting hearing aids, I hate to tell you how long ago that was, all you could do is turn the volume up and down. And now we can do just tons of things, but it requires the skill, I believe, of an audiologist or a hearing aid dispenser who can support you in the endeavor, because getting a hearing aid is a new thing in your life, and in a few months, you'll be able to buy hearing aids over the counter, and that will certainly save money, but it also means that you don't have the support of someone to help you adapt to it, to practice with you, to get it in and out of your ear, to change batteries, to clean it, to get it into its charger. All those things, it requires support. So even when over-the-counter hearing aids come out in a few months, I hope you'll still consider that you might get the best care from an audiologist or a hearing aid dispenser. Cochlear implants are another option. Typically speaking, they were fit on people with profound hearing loss, but the FDA has changed its ruling now so that even people with severe loss can have a cochlear implant and actually do better than with a hearing aid if they have very severely compromised word recognition. So, and cochlear implants, when I started back in the day, it was a 5-hour surgery. You had to stay in the hospital for a week. It made you dizzy and created tinnitus and all sorts of other things. But now it's a come and go procedure. It's all done in the same day. It's a small incision. The surgery itself takes about an hour and a half. So it's much less scary, if you will, than it was a few years ago. What's as much as hearing aids and cochlear implants might be important, staying active and involved. And again, I congratulate you for being here on this call today, because that means you are active, you are involved. So you need to get out there and exercise, even if it means just taking a walk, playing a little ping pong with your neighbors, but mostly getting together and talking to people. Don't withdraw. That's the last thing you want to do. You want to stay engaged because we like to do it. There's other people just like you who also want to do it. So stay engaged. So here's some conclusions for improving the possibility of developing dementia. We want to reduce cognitive load of processing degraded sound by wearing a hearing aid or possibly a cochlear implant. Does that mean that a hearing aid can restore your hearing to normal? No. But in the right hands, it can give you very useful hearing. They can be very beneficial. If you put your heart and soul, and your audiologist does too, you can really improve your communication. Provide increased brain stimulation, do those puzzles, play cards, increase your vocabulary, learn one new word a day, something like that. Try to learn another language, learn a new skill. Don't stop dancing, very important. And improve your social engagement to avoid depression. Don't stay home, don't withdraw, be involved. So that's my story and I'm sticking to it. And I'm happy to entertain any questions anyone might have on any of the topics we covered today.
Oh, thank you so much, Dr. Roggio. This information has really been enlightening, a lot of really good information. So I know we have a lot of questions in the chat. Sophie, do you want to read out some questions for Dr. Roggio?
Absolutely. We have a lot of questions, and we will do our best to get through as many as we can during the session. I do want to let you know we are recording this program and it will be posted at a later date on our AARP YouTube channel, and you will get the link to that. For everyone who's registered here, you will get a follow-up email with that link. One of the earlier questions that we have, Dr. Roggio, is why don't we check for hearing every year, much like one would go get their teeth checked and their eyes checked?
I think that's a great question. We do recommend that once a hearing loss is determined to be present, that you have an annual hearing test. But why people don't do that is an excellent question. Some agencies, such as Kaiser, for example, when they used to do their hearing screenings, they would check everything. I used to be involved with Kaiser hearing screenings. People would just come by as part of vision screening, just a number of different health issues that they would look at. But you're right, it is not a common thing. So we have to get our physicians to make that a requirement. And often they do as people age, but I see people in their 40s who have hearing loss, but their doctor never thought to send them for a hearing test, but they know they're having trouble, so they come on their own. But you're right, we should be recommending that annually.
Great. We have a couple of questions here about tinnitus. What is it, and do hearing aids help with that?
That's another good question. There's a couple different ways to say. I say tinnitus, but many people say tinnitus, so we embrace them both. The reality is we're not sure what tinnitus is. It's very commonly associated with hearing loss, though, particularly high frequency hearing loss. The current thinking is that tinnitus occurs in the brain. the brain is aware that there is something compromised out in the periphery, meaning the ear. There's a hearing loss out there. So we think it turns up the metabolic gain, if you will, and an offshoot of that is some sort of sound, ringing, whistling, humming, buzzing, music. Some people hear music or hear people talking. And they're not, you know, losing it. They really are hearing some sort of strange sound. In terms of treating it, there's no medical treatment yet available, but I can tell you that if you see products that are offering to bring blood flow to the brain, to the ear, that's not going to help tinnitus. It's not occurring in the ear. Even though it may sound that way to you, it's occurring in the brain. That's pretty well established. Hearing aids, just by virtue of amplifying sound, are pretty good at masking the sound of tinnitus, so long as you're wearing it. Of course, you take it off to go to sleep and there's that tinnitus again. It's felt that the best thing people can do, since there isn't any frank treatment for it, is to not fret about it. The more anxious you get, the more emotional you get about it, it seems to get louder and stay on longer. Most of the patients that come to see me because of tinnitus will be, you know, anxious about it at first. And I'll see them a year later for their annual hearing test. And I'll say, how about that tinnitus? And they'll say, well, I guess I have it. I just don't pay attention anymore. And that's the best medicine, is don't pay attention. Now, there are some hearing aids also that have tinnitus programs. They're not really meant to mask the sound of the ringing in your ear. They're really meant to calm you. I know that sounds kind of corny, but that's what it's doing. It puts out a nice, melodious, very soft sound that tries to keep you calm. And that seems to, in their studies, seems to improve tinnitus.
Thank you. How have you found in having perhaps a difficult conversation with a loved one, how do you bring up hearing loss with a loved one who is resistant to treatment or resistant to even talking about the topic? What have you found helpful?
That's so common because, as I mentioned, many people don't come to see me under their own steam. They're coming to see me because their families bring them in to see me. I think, like anything, where we're worried about our loved ones, that we have to approach them with gentle information, give them feedback about how much you like to talk to them, how much interaction means to you with them. And if they can't hear and they're struggling to hear, it's kind of a wake-up call that they have to say, yeah, I have to be honest with myself. And not everybody's willing to be honest with themselves, but you can open the door. I would say not being discriminatory, not being harsh, not being critical. I think those don't help at all. But to be supportive, let's see what we can do to keep you talking, because I love talking to you. I want this relationship to keep going. So what can we do to help you do that? And all Californians get to try hearing aids for 45 days before they have to commit to them. That means you could say, let's just go try it. It costs you a little time, but you get all your money back if you, and believe me, you have to get all your money back. That's a law, just to see if life could be better. And sometimes people will come in, they'll get hearing aids and they'll reject them. They'll say, oh, I don't like them. They hurt my ears. It's too noisy. Lots of reasons like that. But maybe 6 months, a year later, they'll come back. And little by little, gradually, they will accept their hearing loss situation. Eventually, I would say almost everybody falls in that. So I'm just saying, be loving, be supportive, try to give them information, especially about the information I'm giving you now, especially about the relationship between hearing loss and dementia. I think that's very compelling. That would make me try it.
Mm-hmm. Mm-hmm.
Do you have any tips for folks on how to talk with a person with difficulty hearing? What could we do to be
Absolutely. Well, first of all, you want to turn down, we're used to always talking to each other with the TV on. Well, you can do that if you're just chit-chatting about something, but if it's important, you need to turn down that extra sound. Make sure they're looking at you. When you're talking, tell them what you're talking about. So if it's about the doctor's appointment tomorrow or Aunt Sophie's coming for dinner on Sunday, let them understand the topic first, and then they're going to follow you infinitely better. Put the light on your face, not their face, if you have a light. Certainly don't talk to somebody from another room. That's just deadly difficult. Even if you didn't have a hearing loss, it's already hard. But doing that and then being frustrated with it is not helpful. So I think those are the kind of the main things, is being able to see someone's face, inform them of what you're talking about, which I know is artificial. We're not used to having to do that. We want to go back and forth with topics, especially if it's a group. There's 3 people talking, and these 2 are talking to each other, and you don't know what they're talking about. Those people have to stop. And I know that you may not want to do that, but if you want to include them in the conversation, and I urge you to do that, tell them what you're talking about. Get them included in the conversation.
Thank you. We have so many questions today. I'm going to ask this one last question. Please know, everyone, we have saved everything in the chat, and hopefully we'll find an opportunity to get back to you with your questions. But a question about the cochlear implants has come up a couple times in the chat. Questions about the cost and how to compare those options. What can you share with us, Dr. Roggio?
Typically, cochlear implants and the surgery are covered by insurance. Medicare and Medi-Cal both pay for cochlear implants. Typically, they only want you to have one, and there's the jury's still out on whether wearing 2 is very helpful. Some people would say absolutely, others say it adds more noise. Noise is a problem with cochlear implants, just as it is with hearing aids. So I think it's really not a matter of age. You can be 110, so long as you have good health. Health is a bigger determiner of the surgery and appropriateness for the surgery than your age. So don't think I'm too old to have a cochlear implant. That's not the case. And as I mentioned, it is a come and go procedure, all done in one day. Now, there are 3 major hearing cochlear implant companies out there. Usually the hospitals and clinics, and they're usually specialized places, because not every ENT doctor is going to do a cochlear implant. There's very specific ones. In UCLA, Stanford, UCSF, those are places that have specialty physicians who do that. They will offer you all cochlear implants and talk to you about the benefits and drawbacks of each one. So you'll feel well informed. They often also introduce you to other cochlear implant recipients, so you can talk to them about their experiences. They really make it a supportive endeavor.
Thank you so much. Such a wealth of information. Really appreciate the talk. Sending it back to you now, Jacqueline.
Dr. Roggio, thank you again. That was really informative. And I know we probably have a million more questions, but we'll have to follow up with you hopefully on a second time.
Okay, thank you.
Very informative. But before we close out, we'd like to take a quick pulse with a poll. So please check as many that apply. I learned more about clues for getting your hearing checked, where to get your hearing checked, how hearing tests are performed, types of hearing aids, how hearing changes as we age, relationship between hearing loss and cognitive decline, and options if you do have hearing loss. Oh, wow. I think most of us see relationship between hearing loss and cognitive decline. That was really informational. How hearing changes as we age. And also clues for getting your hearing checked. But again, relationship about 85%, 87%. So everyone is taking away something from today. Thank you again very much. And thank you all for taking the poll. Thank you for participating today. We hope you feel encouraged and inspired to think about your hearing health and to speak with your medical professional if you have any concerns. We'd love to get your feedback today, so please fill out our survey. The link is in the chat. Upcoming events, we have the next Tea and Coffee Tuesdays monthly meeting. is Tuesday, July 12th at 9 a.m. And join us for a conversation on emergency readiness with Preparedness Manager Melissa Altman from the Red Cross. Preparedness topics will include what to pack in your go bags for the car or for your home, how to get the latest safety news communicating with loved ones, what to expect if you end up at an emergency shelter. And on Thursday, June 30th at 9 a.m., join us for part 2 of our quarterly money management series, Piggy Bank Essentials with Martin. Martin Booker, a member of AARP's Financial Resilience team, will be discussing the money maker, the second type of money manager, as well as everyday habits that help make us financially resilient and practice money saving choices. If you have any ideas or questions or suggestions for future Tea and Coffee Tuesdays, please be sure to reach out to Atisha Jones. Her contact email is on the slide. And again, thank you so much to our guest, Dr. Marcia Roggio, our moderator, Sophie, our volunteer production crew, Joyce Howard and Vince King, our tech specialist, Connie Moore, our AARP staff, and of course, all of you. Again, I'm your host, Jacqueline Cole. Thank you for joining us today. This concludes our program.